welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, and welcome to Brain Chat. Happy Monday. It's Dr. Mitzi, your board-certified neurologist. I'm so excited to be back with you all in the Brain Chat chair, talking about a topic that is very, very important with two amazing women. And so I'm really excited to bring them up in just a few minutes. But first, I hope everyone had a wonderful Thanksgiving. Mine was very peaceful and restful and quiet, which was great. And you know how we do on Brain Chat. Tell us where you're logging in from. So tonight we're going to talk about MS below the belt. I've got Dr. Mary Hughes with me and Dr. Bry Coleman, who's a pelvic floor therapist. And I'm really excited to talk about this topic because, bowel and bladder function as well as sexual dysfunction are what we call silent symptoms of MS. So when people think about disability related to MS, there are lots of things that people can see very easily and think of as disabling, like if someone has trouble walking, if someone has, trouble with their vision. But there are many symptoms that really can affect people's daily lives that is really important for us to address and really important for you to address with your doctors. And so we are here to put it all out on the table, make sure that people are not ashamed to talk about these things because it's important to your overall health and important to your daily function. So I'm going to bring up Dr. Mary Hughes, who is my mentor, and she is a recurrent guest here on the Brain Chat podcast. She is the medical director of Premier Neurology in South Carolina. Welcome, Dr. Hughes.
Thank you. Thank you for having me.
Absolutely. And then we've got Dr. Bry Coleman, who is a pelvic floor therapist. And I'm really, really excited to hear her take on some of these topics because pelvic floor therapy is something that is relatively new as far as me incorporating and telling my patients, about it. And so I think that this is really important because it involves exercises and things that people can do aside from medications to really help themselves. So welcome to Brain Chat, Dr. Bry. Awesome. Sorry, I feel like singing today. So again, very excited to have you all on. So the first question I always ask is tell us a little bit about yourself and how you're involved in, treating these conditions, whether it's in neurology or in PT. We'll start with Dr. Mary.
So I got involved with caring for people with MS over 20-something years ago now, when I had a family member who was diagnosed. And when I started caring for people, we talk about the meds, but we don't spend as much, or we didn't spend as much time about how to live with MS. Mm-hmm. And I will tell you right now, no one has ever called and said, I just want to thank you for my disease modifying treatment. But if you can help somebody with their bladder control or their bowel control, or have a good conversation around sexual dysfunction that helps build that relationship, then those are really the areas that have such an important quality of life impact. So I think the only article my mom never asked me for a copy of, we had done some educational programs in the early 2000s. So I'm a published author into the International Journal of Multiple Sclerosis Care on sexual dysfunction in people with MS. My mother did not want a copy. I'm surprised to hear how dry it was. But I will say that I'll leave the jokes about other expertise areas alone.
Awesome. Okay. Dr. Bry, tell us all about it. Yeah, tell us about how you got into physical therapy and pelvic floor therapy specifically.
Yes. Pelvic floor physical therapy is such a passion of mine. And I got into it. I was a personal trainer at a gym here in Chicago. I'm in Chicago. And And I kept having clients coming in. You get to a certain level, and a lot of your clients keep coming in broken. And so, I have this shoulder injury, I have this knee injury. I actually had a client who was pregnant and then developed some pain at her pubic symphysis, which is right in the front middle of her pelvis. And it prevented her from walking and turning over in bed and going up her stairs. And so it was really, really debilitating for her. She went and was referred to pelvic floor physical therapy, and it did not work for her. And so we just kind of struggled trying to figure out what was going on. And then she had the baby and it disappeared. And so we were like, oh, okay, well, never mind. And then she got pregnant again and it came back again and it came back sooner. And so that's actually what kind of inspired my interest, even knowing about pelvic as a specialty, was through her experience. And so through that experience, though, that actually did motivate me to want to get into physical therapy. And then as I was on my journey, I actually got pregnant as well, and then experienced all the loveliness of being pregnant. And so
there's so much loveliness.
And so that has been my driving force, is to help people who are pregnant and actually getting through pregnancy, recovering from pregnancy, and then all the stages in between. And so bowel, bladder, sexual function is something that nobody wants to talk about. They kind of ignore it, like it doesn't even exist. And then they also have no clue that physical therapy can help. In fact, we're one of the best avenues with which you can have improvement with these three functions and pain in general. And so I look at everything as an orthopedic condition of pelvic. And so we look at everything starting from the pelvis. So whether you have headaches or shoulders or knees or feet, everything's stemming from what's going on at the pelvis. And the pelvis can unlock or it can reveal a lot of things that can help us along the way. So that's how treating individuals with MS can actually be drastically improved, is because we start from where are we and how can we improve.
Right.
I love it. Listen, I'm ready to sign up. I need some therapy. Okay, but this is not about me. All right, let's get right into bladder and bowel dysfunction, right? So I think that this is extremely vital to people's everyday function. And as you said, Dr. Hughes, oftentimes we can really improve a person's quality of life. I've had patients who've said, I don't leave the house because I don't know when I'm going to have to go, or, it is one of those invisible, or a couple of those invisible symptoms that really, really make a difference. So let's start with talking about the bladder, right? So when I talk to my patients about bladder function, I put it kind of in two categories: either gotta go, or gotta go and can't go. And maybe you're the one who taught me that, Dr. Hughes.
Yeah, it's the only song I sing. Gotta go, gotta go. And if you don't know what that song means, then you don't have that kind of problem with your bladder.
Exactly. Yeah. So tell us a little bit about what happens with MS that causes bladder problems.
So it's interesting you labeled this presentation below the belt, because bladder and bowel and sexual dysfunction in MS actually starts above the neck and the spinal cord, right? So the brain and the spinal cord. And because MS affects those two areas, it's actually almost impossible never to have symptoms of bowel or bladder or sexual dysfunction. There's so many parts of the central nervous system that affects the bowel and bladder. So, when someone comes in, and we talked about nobody wants to bring it up, it's often our role to bring it up and to say, hey, so how many times during the night do you get up and go to the bathroom, or, gotta go, or gotta go, can't get started. When we think about our bladder, there are really two sphincters that are in charge of our bladder control. There's the automatic bladder, that when the bladder fills, the automatic sphincter, when the bladder fills, you get the urge to go. The second sphincter is the one we potty trained, the one that says, not right now, let's hold, not socially acceptable. Let's hold till it's more appropriate. And they both have to release at the same time in order for someone to have normal bladder control. Now, the problem with MS is that because of the nervous, the disorders of the brain and spinal cord, or the areas that's been affected, those two sphincters may not work together. So one sphincter may get the sense that gotta go, even though there's just a little bit in there. There's not a large volume that would normally trigger it. And that's the one we see most of the TV commercials for. All, we're talking about singing, we're talking about the pipes. Most of those drugs that you see on TV are referring to that gotta go, but I just have a little bit. I don't really need to go. The second one is probably the one that gives us more trouble medically. The gotta go right now, that's the inconvenient one. All right. Anybody who's been pregnant, my husband laughed at me at the time, but he's going to get older, and one day he's going to start gotta go, because what goes around comes around.
This is true.
But the other one is when you need to go, you have a large volume of urine in your bladder, but the second sphincter doesn't relax so you can go. And so that's the one that when you're in the bathroom and you feel like you got to go, but you can't get it started. And that's the one, actually, from a medical standpoint, we need to be more concerned about. Because if that urine sits and doesn't empty normally, that's when we get an increased risk for bladder infections. Now, the secret to it is when people say, well, I never talk about sex in the doctor's office. I mean, where else are you going to talk about it?
Right.
Is that if I know you have bladder problems or bowel problems, I already know you have sexual dysfunction. So it just comes with the territory. So you'd have a hard time surprising us. It just may not be, I was raised Catholic. We didn't have a lot of conversations around that for many years of my life. But it is such an important thing to bring up and to be aware of, and just say, hey, it comes with the journey. There are many things we can do about it. And it's such a satisfying area to be able to intervene with. So that's what we think about from, what's actually going on. Yeah. Sexual dysfunction is a little different because it has, so first of all, is like where primary sexual dysfunction is like where the nervous system is injured and it's affected that the nerve ending. So you don't have the normal lubrication. You don't have the normal blood vessel responses, the motor control. The secondary is, spasticity. So how many people who have increased reflexes when they go to get their toenails done say, almost kick the manicurist, the pedicurist in the head, right? A little bit of stimulus in the leg jumps. So spasticity can be a problem. If you have increased tone, you have abnormal sensation. And so if somebody's just rubbing you away on your thigh and all you can think is that is about to drive me out of my skin because it's so uncomfortable for me, right? From abnormal nerve sensation. So that medication side effect, these are all things that we need to be thinking about in the differential. And then the third is tertiary sexual dysfunction, is the one we all know about. The one that says, oh, I don't want to try on bathing suits. I don't feel quite as good with myself. Maybe I'm not as confident as I used to be, or I don't have that same esteem as I used to. And those thoughts, again, that interfere with our feelings of being a sexual being and a desirable sexual being.
Absolutely. So thank you for that, Dr. Hughes. Now, if we think about, so there are a lot of things that you said, but when we think about bowel and bladder function, a couple of those symptoms or descriptions that you talked about kind of have names that we call them in the clinic, right? So there's frequency, which you described as a gotta go. There's also urgency, which is gotta go. And if I don't get there right now, I'm going to have an accident. Right. And then there's also retention. And so that's the one where you feel like you can't get it started or your bladder is holding on to urine. And those sphincters are muscles, that, as you described, either don't relax appropriately or don't work in conjunction to allow people to urinate when they're supposed to. Something else that I think is very important for us to point out is that people can have bladder issues for other reasons, right? People with MS have kids, men have prostates, so Dr. Bride, tell us a little bit about some of the other things that can cause bladder dysfunction that maybe aren't necessarily purely neurologic for like people with MS, things that you see in your practice as causes of bowel or bladder dysfunction.
And I'm over here just nodding at everything that you're saying because to be honest, I have only treated maybe about 2 or 3 patients with MS, and still everything you said applies.
Absolutely. Absolutely.
Absolutely everything you said applies.
Absolutely.
Absolutely everybody. It's this neurological connection to our body that we somewhere along the way lose. And so it just gets where it's not calibrated correctly. And so that's what we see all the time in physical therapy. What causes it? You're absolutely right. Everything that you said, plus how we feel about it. And you were kind of talking about that. How we feel about those things can cause trauma in the body. And so that one time that you didn't get to the bathroom and you had an accident in public, that just increased your urgency tenfold. That just increased your frequency tenfold, because now how you feel about that urge is so uncomfortable that it sends a threat level through the roof. And now you have this overreaction to a natural sensation that now needs some help reprogramming. And so, and healing from that trauma and actually looking at it as trauma versus, oh, I don't know, that's just how my body is. No, it's actually addressing the issue and saying, this is how I actually feel about this. I feel insecure, like you said about the bathing suits. Absolutely. Somewhere along the line, we get this self-consciousness about our body, and then we actually harbor that, and harboring that can lead to bowel, bladder, and sexual dysfunction. It can lead to an overactivation of our pelvic floor, because our pelvic floor, that's what happens with our body, right? Is that it gets tight when we feel scared. And that's what happens at our pelvic floor. It gets tight to protect us and just to keep us a little bit more safe and on ready, and just to be in that fight, flight, or freeze state all the time. And sometimes our body needs that coaching in order to get back and activate that parasympathetic nervous system, or that rest and digest, that let's chill place of being. And so I think that that's what I see most of in my practice, is that I see a lot of people that are very up here and need some help coming back down here. They need some help feeling safe again in their body, with their sensations, with their neurological connections. I often call myself a interpreter. So you tell me what your body's experiencing, and I tell you what your body's trying to tell you. Because our body's trying to tell us what it needs. And so if we can just listen, or if we can get some help translating, then we can actually give it what it needs and hit that right at the root. So although it may not be a complete disease process like MS is, it still has the same neurological pathways, the same feelings, and that sense of kind of ownership, where it just wants to protect us.
And I never thought about it like that. Go ahead, Mary.
I have a question. So and you can tell me if I'm wrong with this, but every woman's magazine, at least once a month, or maybe once every 6 months, has an article on how to do Kegels. And it turns out what very high percentages of us, others, because I'm not including myself in this conversation, don't do them right. And is that when I send people for pelvic floor therapy, we have a fabulous one, and we're actually seeing women's clinics that are starting with pelvic floor therapists. Men urologists are way ahead of us on this. So if they're operating on the prostate, a lot of them will insist that men go before they have the surgery, so they can enhance their bladder control after surgery.
Yes.
So is it true that we're doing the Kegels wrong? And is that something that you're helping people do? And why do we need to do a Kegel right in the first place?
That is that's a twofold problem. So one, it's not necessarily that we're doing them wrong. It's that we're not doing them at all. And so where we think that we're sitting there kegling away.
So we ain't even doing Kegels. We doing Eagles.
Or we're squeezing our inner thigh. We're squeezing something that's not your pelvic floor at all. That's one. Two is that some people, especially with the people I just talked about, they have no business doing Kegels. No business doing Kegels because their muscle is already too tight. And so when you were talking about being spastic, right, and actually having that increased tone in a muscle where that muscle is just sitting tighter. So it's similar to like my shoulders, right? And so if you're walking around all day here and this is where you exist, this is where you type, this is where you talk on the phone, this is where you talk, like this is just where you are. Then you ask me to lift my shoulders. Where are they going? So a Kegel is basically a lift of the pelvic floor, right? Well, if I'm already here and locked up, first of all, my neck is already like screaming at me. I don't know if you can see my neck, like screaming, like please put your shoulders down. And so that pain is actually being, it's being presented to my brain like, yo, you need to do something different. And so what we really start with in pelvic floor physical therapy is to teach folks where their pelvic floor should be. Okay. So now I feel better already. Okay. And so first teach you how to chill out, relax, and get some length to the pelvic floor. Then I can teach you how to do a Kegel, right? I can't come in day one and be like, hey, let's do some Kegels. Or I can't not even assess your pelvic floor and be like, yeah, just do some Kegels. You'll be fine. No, because if I'm here, where am I Kegling? Where am I strengthening? I'm not. If you were to ask me to lift, let's say my arms, it's like I can't even have range of motion in any other thing. So now when we're talking about function of the hips or function of the low back or function of the knees or function of your shoulders, how can we have that range of motion and that function if we don't have a stable base of support? And so we first need to get some length in that muscle before we can have strength and control over that muscle. So when we're talking about bladder control and we're talking about bowel function, which we haven't really talked about yet, but both of those are about being able to have control over a muscle, not just strength. Okay. And so we don't just need to be walking around carrying 100-pound weights all day. We need control. We need a volume button. I often talk about a volume dial. So in your car, your radio has it on and it has it off, but it also has control of the volume. So not only can your radio be on, it can be loud, it can be soft, it can be somewhere in between. And that's where our muscles need to be. They need to be on, they can be off, but if they're on, they need to be somewhere here. Like, do we need to be all the way up so that we're running from a bear? Or can we be somewhere in the middle where we're just walking around having balance and having function? And so that's where we want to be, is we want to have control of these muscle groups, not just strength.
Okay. I'm learning. Are you learning, Mary?
But I also want to make sure that we really talk about that. That's not where we start in the clinic, and that we don't have to. We start at a much more basic level when we're talking about bowel and bladder control. But okay, all right. No wonder we have those every month. We're not doing it right.
Right.
Well, some people don't need to do it, right?
Yeah.
So, thought about that. Talking about the spastic legs and everything.
Right. We can't just write an article and be like, everybody should be doing Kegels, because that's actually making some of our problems worse. Is that then we're teaching our pelvic floor that it needs to be here and this is where it should be, versus being able to have control and length of our muscle. And so that then again reprograms our brain to think that this is normal. And so that's what our brain does, right? It adapts to whatever our new normal is, right? And so as it gradually adapts, that can change our perspective as what is normal.
Okay.
Yeah, I mean, I think that's very interesting, particularly when you were talking about how, if someone has, a certain episode, it can kind of heighten, awareness or anxiety around, certain triggers for using the restroom, et cetera. Like, I think that's really important, for us to think about. Now, when we're in the clinic, right, and we say, okay, someone has this issue, let's say with bladder dysfunction, right? Let's kind of take a step back and think about kind of what are the ways that we approach treating a problem like this. So Mary, you have somebody that comes in and says, I've got, gotta go. I've got urgency. help me out, doc. I'm having trouble leaving the house. I don't know what to do. How do
Okay.
we treat that, from a medical standpoint, or what are some of our options? Because those options obviously have expanded,
Right.
you know, um, even over the past several years.
Right.
So let's start there. And then, Bri, I want you to talk a little bit about kind of what we're doing with pelvic floor physical therapy. But start with you, Mary.
Okay. So the first thing is to figure out what kind of bladder problem are you having, right?
Right.
Because we don't want to be wrong. We don't
Hmm.
want to have somebody who got to go, and we give them something for urinary retention.
Right.
So the questions and really being able to talk about that is the frequency. We ask how many times during the night do you get up and go to the bathroom. We always want to make sure we're not missing signs of infection. Do you have any discomfort, any burning, any pain? Um, have you had any problems of prolapse and those kinds? You always want to kind of medically make sure that you're not missing something from that standpoint. The majority of the medicines that we see on TV, the got to go, the pipes, those are all for I get a little bit of urine in my bladder and I have the urge to go. All right. The other thing that is sometimes used for that more often or more frequently now is Botox. Just like we relax the muscles in the face so that people don't have wrinkles, Botox in the bladder is not is for many a very effective option, because I know there are many people who are probably listening to this show and they're like, I've tried everything. And no, you haven't. All right. It's very rare to meet somebody, no, you haven't.
Right.
And sometimes we just have to get out of the easy things first, which is
Hmm.
meds. The easiest thing is to ask, how much water are you drinking? And people who gotta go, they cut back on their water.
Hmm.
And the problem with that is you concentrate your urine. Guess what? Concentration urine is a stimulant to gotta go. So you
Right.
really do have to drink your fluids. Um, we have to ask about bowels, because constipation can lead to urinary urgency. So these
Hmm.
two systems talk to each other. So we have to make sure we have to ask those questions about bowel, either constipation, and opening the door for the conversations for the rare person, but they do happen, who have bowel leakage. All right.
Hmm.
And to be aware that that can both, while it's much less common, obviously socially people tend to really feel much more uncomfortable about going out in public.
Hmm.
Once we've kind of really kind of got what we call the bedside, if I hear someone say, I don't even feel like I have to go, and all of a sudden I'm wet, I worry about if they have urinary retention, right? The urine is sitting in the bladder, they don't get the urge to go, or they can't start it and it just spills.
Hmm.
And that's the person that I'm going to do a bladder scan for. We do ultrasounds of the bladder. We're able to do it bedside in the office, but sometimes we have to involve a urologist as a first line, just looking to see. So we can scan the bladder like an ultrasound before someone goes to the bathroom and sees how much urine is in there. We can send them to empty it, and then when they come back, we look to see if they were able to empty it. If you're not able to empty it, that leads us down a different road. And you can
Hmm.
get even more sophisticated in looking at that with urodynamics, which is done by the urologist. And really, the key thought around that is we don't want to miss somebody who's not able to empty their bladder, as urinary retention, because that can affect the urine splashes up the ureters. You can start getting kidney problems. Very
Hmm.
important to identify.
Hmm.
So water, 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 water.
Right.
Looking at medications, if you have the urge, that may be helpful. On the urinary retention, looking at the medications to make sure you're not on something that may make it harder for you to may have retention as a side effect. Men, we don't check prostates in neurologic offices. So
No.
always, no, we don't. And we don't do bladder, we don't do pelvic exams either. So we send you to the appropriate people to make sure that your anatomy is correct, to make
Hmm.
sure we don't want to be treating you thinking it's related to your MS when it's actually related to an enlarged prostate. All right.
Right.
The treatments for that are very different. Um, from a bowel standpoint, I think we all have our cocktails. The first thing is water, water, water. Um,
Lots of water.
lots of water. And then fiber, fiber, fiber.
Lots of
Everybody
fiber.
thinks they eat enough fiber, and you
They
don't.
don't.
And so, not uncommonly, I'll recommend some of the supplements like Benefiber. We all kind of have heard of Metamucil. Maybe we haven't tried it ourselves, but it turns the water kind of gunky. Benefiber is clear. You put it in there, you can't even tell it's there. I'm not going to tell you how to know. You can put it in your coffee. I don't know about carbonated drinks. I've never actually had anybody come back and tell me. I would think no.
Probably not.
Probably not. But a tablespoon of Benefiber in the morning coffee. Coffee sometimes can be a stimulant. Miralax has been a game changer for many people. It is pulls the water into the intestines to help move. So it's a laxative, but not a. We don't want to X-lax. The stimulant laxatives, because over time you may end up with a bowel that no longer responds because it's been stimulated so many times. Stool softeners.
Mm-hmm.
We kind of started talking about what it was like to be pregnant. I don't know any pregnant women who didn't have to use a stool softener. So Colace, available over the counter, taken twice, 2 or 3
All
times.
of these things are over the counter.
And the funny thing about it is we kind of put these tools in the hands of people. And then sometimes you need a little more of this and a little bit of that. Oops, that was too much. I was constipated and I'm not now. And so kind of having what are the first steps? I don't use a lot of the newer agents like the Linzis, and some people may find that helpful. That's just not a main tool in my toolbox. I don't know, Dr. Williams, do you ever recommend?
Not usually. So I usually leave that to our GI colleagues who are a little bit more familiar with that one.
Yeah. Mm-hmm. That's not a common thing. No one wants to hear it, but when you're constipated, exercise, exercise, and exercise. Oh my gosh. Oh, did I get an A+ for that?
Yes.
I tell you, people think we're not paying attention.
If you get moving, it will start moving.
Oh, I like it. I'm gonna start using that in the office. They think I've changed the subject. I'm like, "Are you exercising?" And they're like, "I'm constipated."
And they get so mad at you.
Constipated. And these are just. I love that we're laughing. I love that we're, because you know what? I don't know anybody who hasn't been constipated at least once. All right. And they're such normal things.
Right.
And in our offices, we go from room to room discussing bowels and bladders. And if we're feeling particularly brave, we get into sexual dysfunction. But just knowing that these are just normal things. All right.
Right.
They're not things to be ashamed of. They are. We already know you have them, or you have a very high chance. And if you don't have them now, you probably will have them. So having this healthy conversation around it becomes very important. Hopefully, just to open up the door. And if you are seeing a neurologist and you haven't brought it up, right, or you're uncomfortable about it, bring it up. And sometimes, I will have to say in neurology, we didn't spend a lot of time talking about bowels and bladders. But because of the interaction between the nervous system and the bowels and bladders, this has become bread and butter for us. But your primary care physician may not understand some of the subtle differences because of the relationship with MS. But certainly opening these conversations is so important.
Yeah, so I heard so much, right? So number one, we've got to talk about it, right? The neurologist, the practitioner has a responsibility to bring it up. And then you as an individual living with this, or a care partner, right? If this is an issue, we need to talk about it. We cannot help or deal with issues that we don't know exist, right? So there's really no shame in talking about it, because we want to make people's quality of life as good as possible. I think the other things are, sometimes there are referrals that are appropriate, right? In some cases I may refer to a urologist. So neurologists may do Botox for many things, but I don't do Botox for the bladder. Right now, you got a headache, I can help.
Set up in our office.
Listen, we ain't doing no bladder.
We don't have the setups. I'm sorry about that, Dr. Rivers, but we don't have the setups in our office.
Right. We listen, and neither do I desire to. But I will say that over the course of my career, I really have seen management of these bowel and bladder issues change. We had a lot more people with catheters. I
Mhm.
remember when I first started practicing than we do now, right? So now we have things like Botox, there are bladder stimulators, right? There is
That are
pelvic
now
floor
MRI
physical therapy.
compatible.
Yeah, that are now MRI compatible, right? So there are more things that we can do um, that will help keep people mobile and moving around, and they don't have to carry, catheters as often as they used to. So again, let's go back a little bit and let's talk about the role of pelvic floor therapy in. You talked quite a bit. You talked some about it with bladder dysfunction, but what about bowel issues?
Bowel is huge because a lot of bowel issues are again twofold. So I talk about, are you really constipated? And so with constipation, right, we think about it being like this slow moving gut where our gut isn't really working well, and so it's just staying in your body for too long, but we don't really talk about the actually expelling of the stool, right? And that can actually also feel like you're constipated, the fact that you actually cannot get this stool out of your body. So maybe your colon is working appropriately, but your pelvic floor is so tight that it won't actually open. And so when we are talking about bowel and sexual function and even bladder function, but those two other ones are huge when it comes to relaxation of the pelvic floor. And so for bowel, your pelvic floor should keep you continent. And so, in order to have a bowel movement, it actually has to stretch and relax in order for something to actually exit your body. And so, if you are having a hard time relaxing, if you're having a hard time stretching, if you don't feel comfortable with the feeling of a stretch, that also can feel like a threat. And it can be extremely painful. It can be something that your body then reprograms to hold in instead of wanting to let go. So many people push and strain in order to have a bowel movement. Well, you're pushing and straining, you're getting tighter and tighter rather than open. And so you're actually doing the opposite of what you're intentionally trying to do. So it makes having a bowel movement difficult, and some people even equate that with being constipated when actually they're just having trouble pooping. And so I kind of try to differentiate between those two, like what's really our issue. Okay. Same thing with sexual function is that we actually need to be able to relax our pelvic floor in order for it to be functional, in order for it, you to allow blood flow into places that we need to have this blood flow, to stimulate nerves in our pelvic floor, to stimulate having actual enjoyment in our sexual function, right? Because sex for humans should be fun. So if it's not, if it's painful, that is a problem, and it is not supposed to be that way. And so part of that is that our pelvic floor is just too tight and it's having trouble relaxing. So it's similar, like if you had a knot in your neck and your loved one comes over and starts rubbing your neck, you're like, gosh, that hurts, don't touch me. Same thing, right? And that can happen in the same muscles in our pelvic floor as they do our neck. And so thinking about that and all of our concerns that we have, that we bring up to our doctor, that we feel comfortable bringing up to our doctor, these are all still muscles. And so when you think about it that way, bring this stuff up, especially if you have MS, because again, like you said, it's just down the road. And having that conversation early before you have a problem can prevent so many other problems, or it can make you have better control. And so knowing that these products are on the shelf. So if you are having trouble with this, that's great. Knowing that increasing your water and increasing your movement can help prevent constipation. That is a tool in your toolbox that you can take with you forever. So then you can see those signs, you can notice those signs, and they're not threatening because you have something to have control over and to be able to help you. And so I often see people in my office after it's already a problem. And so, and I wish that we can get to people earlier rather than just using our doctor's visits to talk about things that we're concerned about. I really, really urge people to talk about all things, right? That maybe it is occasional constipation that you're having an issue with. Just because it's occasional does not mean that that's normal for you. Like, let's go ahead and talk about that. Bring that up. I urge doctors to also bring it up, like you mentioned. Ask someone about their function, and stop acting like this is a shameful thing. Well, I won't mention it until they bring it up. Like, no, like, let's talk about it. Let's bring it up. Let's have these tools in our toolbox so that we have better control. We have better ability to not freak out when something bad happens.
And it's very interesting because as you were talking, earlier, Dr. Hughes, I was thinking about this concept of prehabilitation. So, kind of what you talked about before someone has the prostate surgery, they send for therapy. So there's this concept. It's still kind of in its infancy stages as it as it relates to multiple sclerosis. But certainly, we've seen in other fields where people don't wait until there's a problem, but you do strengthening beforehand, right? So that if/when you encounter the problem, at least you've got some baseline where you know the right things to do, and then we can rehabilitate later. I wonder how this would work. I mean, first of all, you got to get insurance to pay for it, which they usually won't pay for it until you have a problem. But I think it would be interesting to think about that concept.
But I think we do in MS because, in a certain extent, because when someone gets a first diagnosis, we spend a lot of time talking about potential problems, right? Like you may not have bladder problems now, but if you develop them, know that there are tools for it. If you, we ask these questions because there are treatments for it. People don't come into us and saying, I have spasticity. We ask those questions. Do you have tightness? Do your muscles ever jump? I think one of the things that there's been a much increased awareness around the importance of relationship and mental wellness, not physical wellness. Yes, physical wellness, but mental wellness, and talking about those aspects of life: mood, anxiety, depression. No one's depressed and want to have sex at the same time, right? We have to address that, but we also have to be aware that some of the medications we take for depression may lower your libido. So keeping that at the forefront, just making sure you're aware from it. I think there's some great resources out there. I know the National MS Society had one, and I wish it's probably something as simple as sexual dysfunction and MS. They're not very creative with their titles. And I laughed. I said it had like a 1970s couple, and they're gazing at each other. The picture's not all the way in focus. And I used to hand it out in the office. I never read it because it looked boring. And one day I opened it up and almost had a heart attack because I should be like put it up where the kids can't get to it. But there are some very simple things that are steps. One is communicate. And so the body mapping exercise, I thought about that when you said, you're rubbing on this tight muscle and you think you're doing something, but it's hurting, and communicating. So this is an exercise where you're going into the room, and it is not about sex. It is about communication. It's about saying what feels good, what doesn't feel good. It talks about, my left leg cramps when I get in this certain position, or, so it's really discovering what feels good to each other. All right. Hints around the body mapping. Well, people with MS, things don't work as well when they get hot. So it's usually a cool room. All right. And if sensation is down, then what are some of the things that we can do to increase sensation? And so it's giving permission to be creative. All right. And using mechanical stimulation to try to enhance sensation. It is saying to your partner, it's not because you don't turn me on. It's because I need more stimulation in order to reach that same sensory. It is if I'm hot and I'm uncomfortable, we're going to have to turn the air. You can put a sweater on. I can't take much more off. All right. Those communication things around. And so I think these things, as I was reflecting on the topic for tonight, I've been talking about this for about 20 years. Tools haven't changed, right? I think pelvic floor therapy is more available. I think prostate surgery and prostate cancers is probably what started the availability more than anything else. I know that's what kind of drove it in our area. Um, the communication hasn't changed in its importance.
Mm-hmm.
But how do we bring that up? And sometimes in limited office visits, we don't have the time to, I may not be able to review your MRI, discuss your disease modifying trip, check your labs. But if I know that's an issue, I'll make an appointment just to bring you back to discuss those things.
Right.
But looking at those resources, and I don't know, Dr. Mims, if you ever list some of the resources available.
Mm-hmm.
There are many organizations that have focused on MS, that have publications, handouts. You can go to their websites. They really talk about some of the tools, tools for fixing the problem, tools for communicating about the problem, tools for where should you go next.
Right.
But I think this is the important thing is it's not something you have to do by yourself.
Right.
That if you're not comfortable having these conversations with your neurologist, then you might need to get another one, because these are things that are part of caring for people living, and the key word is living with MS. And these resources are out there. And you may have to be the one to knock on the door and just say, hey, like, I really like talking about my constipation. I don't think this is normal, right? And that's okay. Because once you've opened that door, hopefully you can find those resources that you really need.
Absolutely. And I think, there's so many things that you said that are key. The other thing is, I often encourage people to bring their care partners to a visit, right? I call them truth tellers, right? So my patients over there like, I'm doing fine. And their wife is like, no, you're not. No. So if you maybe don't feel comfortable, bring somebody with you, right? That can help assist or make you feel more comfortable in that conversation. But I think that, all of it, when we talk about treating these issues, I always say there's a part medicine plays and there's a part you play, right? And there's no medicine that fully gets rid of the part that you play in helping your overall health, whether that is going to pelvic therapy, whether that's taking that Metamucil or Benefiber, exercising to get those bowels moving, drinking that water, all of those things, right? So there are always things that, individuals can do to help. And I think that that's important to underscore with a condition like multiple sclerosis, where many people often feel helpless, right? And they feel like there are things that they can't do. So I think that that's extremely important. And looking also at a holistic approach, right? Realizing that mood affects sexual function, that mood, whether it's anxiety, can even affect bowel and bladder function, right? That all of these things are connected, and we have to address all of these things to ensure that people are living well with multiple sclerosis. So we have said a lot, ladies. Listen, we covered a lot of ground because, we could do one show on each of these topics, right? So you all are amazing. Why don't we just have you give some parting thoughts to our audience and all those who are tuned in watching the podcast? Any parting thoughts?
Yes. Well, my parting thoughts. I just wanted to touch on one thing that you had just said, which was, good luck getting insurance to cover like a prehab situation. First, you got to be broke before they can actually allow you to be fixed, right? Well, there's a ton of therapists out there. I know there's a ton of pelvic floor physical therapists out there that are out-of-network providers. And what that means is that we can actually provide care on your terms. And so we're not reporting to any higher up that's approving our ability to care for you. You can take that step to choose to be with an out-of-network provider and go after the goals that you value. And so that's sometimes a big hindrance, especially in physical therapy in general, is that we get a script from your doctor saying you can look at just this part, and that's just not how the body works. And so, and that's already after it's, you're gone to heck. And then, you're coming in for this one thing, but this, and that is also really, really bothering me. And as a physical therapist within the system, that's really tough that's bothering you. I have to address this. And so it's really kind of ties our hands behind our back when it comes to a holistic approach to the full body and to the full person. And so I really do want to encourage folks to actually take their health into their own hands. And if that is hiring a professional that has your best interest and your goals at heart as well, like you said, if that neurologist is not talking to you or not listening to you or does not make you feel heard, pick a new one because
Right.
there are more fish in the sea. So, and that's what I just want to really champion everyone out there to take a further look and take a deeper dive into what you value, because there are therapists out here that do not have to work within a bubble. We are out here over the rainbow with these goals. So I just wanted to mention that as well.
Awesome.
Bowel, bladder, sexual function might be this little thing that sneaks up on you, but there are definite telltale signs that are screaming like, hey, you're about to have some pelvic floor dysfunction. And it can be MS, it can be back pain, it can be headaches, it can be a plethora of things. So really do your research and get out here. I'm on the Mobile Mommy PT. There's a ton of other physical therapists out there that give awesome information on social media. And that's also a tool that you can use. Just gotta, make sure who you're listening to is
Right.
actually telling you
That's
the
a
right
great
thing.
place to tag on. Your best advice does not come from the barbershop. And I think we all know there's been a potion or a pill or something that's been touted to help with all the above. And so I think one of the challenges with living with MS is that the people who do the best are the best informed, the best who really have a sense of self-efficacy, where they'll go out and try to really help with that. And the challenge with that is sometimes with MS, you don't feel so well. All right. You're tired. You're just like, I don't know. But these are the things that really increase quality of life. And that's what it's all about, right? And so, we mentioned some of the tools, being aware of the quality of your information. But you said value yourself. How important is it? And I think most of us would say you're worth it. And so just opening up those conversations, and you may be surprised that it may not be that much that makes a difference in your life. And that's one of the reasons why I'm a huge fan of Dr. Williams at the Nerdy Neurologist. She's not paying me to say, she's not paying me at all. She's paying you. But the point
In
of
love.
that she's giving us a platform to talk about things that are so important, right? So I thank you for doing this, Mitzi, Dr. Williams. And this is where, I want to thank the audience that took the time to listen in, all right? To say, this is the first step. And maybe it's one of many steps that you've taken. But I think each one of them be worthwhile. And I wish you well with living with MS. And for the rest of us who don't have MS, we learned just as much, didn't we?
Absolutely.
We did. I was like,
listen, I'm taking note. I'm taking notes seriously. Well, thank you so much for this wonderful, wonderful information. I know this going to help those that have listened and tuned in, and those who will listen and tune in later. So thank you everyone for tuning in to Brain Chat. We will see you in 2 weeks with the next episode.